So the wire's staying,
The
or the wire's going
being,
along with the catheter?
The wire is preceding the catheter.
Preceding.
You're pinning the wire once the wire goes over the aortic arch.
Okay.
The doctor, you're creating a rail so the doctor can advance the catheter over the wire, over the arch, into position to cannulate the left
So
vein.
you're watching the screen, so once you see it goes around over that, that's when you're planting the wire.
You're advancing, as a tech, you're advancing the wire, making sure it doesn't go into the left subclavian, the left carotid,
Gotcha.
the brachiocephalic. If it does, gently pull the wire back.
I'll let him know.
Wait for the catheter to come over, and then once the catheter's over the arch completely like this, then wet gauze in your left hand,
Right.
wire comes out, just like this. Did you notice the blood that was on the wire?
Yep.
I'm wiping off blood so it doesn't turn into a blood clot.
Gotcha.
And now, we're ready to hook up. So the doctor will hook up to the catheter.
So sometimes it doesn't necessarily have to be all the way in.
No, the catheter will not be.
It
Will never be hubbed from this hub to right there.
It's never hubbed. Okay.
If you have Shaquille O'Neal on the table, who's almost 8 foot tall, if you have someone that's really tall, then the hub is going to be, then it will be hubbed.
Right.
Okay.
Gotcha.
But you'll typically have about 15 or 20 centimeters of catheter out of the proximal end of the sheath. Okay. So now we've connected to our manifold. This is why you guys have to practice manifolds. Okay. Because this is not set up, I'm not going to be able to do this. But right now, I would turn off to all the side arms. I would aspirate until I see blood coming back like this. We're not going to see air when the system's initiated. If I do see air, I continue to pull and I waste the air. Okay. But we aspirate back. Once we're clear of blood, okay, I can't do this because it's not pressurized. But I will aspirate, and then I will flush and clear my line. I can't do it right now. So try to do this so that my line's clear. Okay, on to pressure. The doctor will be up here torquing the catheter like what I just did on the Symbionics. Once I'm actually in, or once the doctor is actually in the ostium of the left main, you then start to take the pictures. This is where you go iliocranial, iliocaudal, ariocaudal, ariocranial. You do the around-the-world shots. Once the doctor's happy with the images from the left coronary artery, the doctor's going to disconnect from the manifold, disengage from the ostium of the artery. You're back here waiting for the doctor. Once they've done that, they will take the wire from you. So the doctor will put and I don't have gloves on, it makes it easier if you have gloves on. The wire in. While the doctor is removing the catheter over the wire, you're back here grabbing your JR4, having it ready to go, wet gauze in your left hand. So the doctor will grab wire here. You will wipe the wire down, take your dirty JL4 catheter, throw it on the back table. Wire's already wiped. You already have your JR4. Whoops. This is another thing. It's the best way to do. Take the hub of the catheter, put it between your ring finger and your pinky. You have control. You don't want this hub to fall off the table. This is a sterile object that's going in the patient. Now you have control of the tip of the catheter and the hub of the catheter.
Right.
So,
I got a question real quick
sir.
before we go any further.
Absolutely.
With the wire, when you were pulling it back, the catheter back, the wire did come back. Is that the time that you want that wire to stay? Or do you want that wire to be pulled back?
Excellent question. The wire's going to have to come back slightly because the wire is only 150 centimeters long and our catheter is only 110. So I'm going to have to pull wire back, but not all the way out.
Okay.
So it's an excellent question, very observant. Our wire should be somewhere right here in the middle, right there. So I was going to point up here. It's right here.
Okay.
So when we go in with this next catheter, okay, to answer your question even further, you're going to put the catheter on the wire like this. Okay. You're going to advance the catheter over the wire to the doctor. The doctor will take the catheter from you. You will see your wire appear right here. You're going to straighten the catheter out so everything's coaxial. And as the doctor advances the catheter in the sheath, you're then going to ask the doctor, can I see? So they're going to fluoro, and then the wire tip is then going to be pushed by you up the aorta, and the doctor's going to be advancing the catheter
at the same time.
And you let that wire go over the arch. If it goes into one of the great vessels, pull the wire back until the catheter gets there. But you're basically doing this.
Okay. So you're advancing the same time the doctor's advancing.
You're advancing ahead of the doctor.
Pretty much ahead.
Precede the
always
position.
preceding.
Always, yes. So And then
But
once
not
the
by a
catheter-
lot, though. You're talking
No.
an inch or two,
Yeah.
right?
But,
Maybe
yeah,
an inch.
We're talking, the wire should maybe 4, 5, 6 inches ahead of the catheter.
Okay.
Realistically, what's going to happen is you're going to be back here advancing wire as fast as you can smooth. The doctors are going to have the catheter up over the arch. Should the doctor do that? No, they should not. They should not advance the catheter without the wire
They
first.
get so comfortable with everything.
They don't have time to wait for you.
Just-
Angela, if you're not going to stick with me, then get off the table. They're going to be rude at times. Are you recording that? Show that to a doctor. Sorry, doctor. Okay, so once the catheter and once the catheter's in position, you have wet gauze in your left hand. Doc, do you have catheter? Yes, I got catheter. You remove the wire from the catheter, coiling it into a nice, neat little coil. Got your towels. That wire's not going anywhere. So now, the doctor or you, sometimes they won't have this extension tube. Sometimes the doctor will connect right into the catheter. Once the catheter's been connected, the next thing we have to do is flush the catheter again. So the doctor will take pressure off, aspirate, they'll get blood back into the catheter. Most doctors, once they see blood come back into the catheter and they're sure there's no clot or air bubbles, they'll inject right back into the patient. What I'm going to teach you guys to do is aspirate, so you get blood in your syringe, then waste it. And then you get your one-way valve allows you to aspirate saline. You can't do it because it's not pressurized and the system's not on. But you'll get a clear syringe of saline, aspirate until you see a flash of blood like that, then flush. Notice I'm tapping this the whole time. These air bubbles, I would not flush into a real patient. You want to make sure there is no air going into that artery because you're going to stroke somebody. Okay? So anyway, so once the catheter's flushed, the doctor may say, okay, Paige, inject. And the doctor will be up here trying to cannulate the artery, and you're testing, just like what I was doing on the symbiotics. That's why we have to learn this. Okay? When you're not testing, you're on to pressure. When you're not on the pressure, you're either wasting or testing, or aspirating contrast. So once you get into the coronary artery, the right coronary artery, LAO, do your picture. REO, do your picture. When you see the doctor do this, that means they've disengaged. You should be saying, what's the doctor need next? They need the wire. You have the wire. The doctor will disconnect from the manifold. The wire will go in. Typically, the doctor will advance the wire like this. They'll get to this point where they'll start removing the catheter over the wire. You have the wet gauze in your left hand. Doc, do you have wire? They grab wire. You wipe the catheter on the table. What's the next catheter we need? The pigtail. Okay? So, when you grab a pigtail, don't have it in profile like this. Have it on end. So you have the hub of the catheter between your ring finger and your pinky. Slide your finger up the shaft of the catheter and straighten the catheter tip out. Now, you can put it on the wire much easier. Okay? And the doctor is holding the wire. You're advancing catheter over the wire until you see this. Straighten the catheter so it becomes a coaxial system. It's straight. It doesn't have play in it like this. It's completely straight. You're pinning the wire while the doctor advances the catheter into the sheath. Then the doctor's going to fluoro. You're going to see the wire. You may have to advance the wire so that it goes up over the aortic arch first while the doctor follows with the catheter. Okay? Once the catheter is, there's the wire. You can see the wire up there. Once the catheter is over the arch, okay, because this is a pigtail, what do we do with the pigtail catheter? We do an LV-gram, left ventriculography. We look at the pumping chamber of the heart. So the doctor will take the catheter, grab it by the hub, take their other hand with the wire, and they'll try to advance across the aortic valve into the left ventricle. Okay. Once the doctor gets across the valve, they will advance the catheter into the ventricle, and then you have to be ready, because the doctor's going to do this. And then you have wet gauze in your left hand, wipe the wire, okay, put the wire down. The doctor will connect to the manifold. Oops, not pulling the catheter back. They will aspirate and flush, go on to pressure, and say LV. What that means, they will put the manifold down. They say LV to the monitoring tech in the back so they can capture the pressure waveform in the left ventricle of the heart. This pigtail is now across the aortic valve in the ventricle. And when I get rid of all this blood, you'll be able to see that. Okay. Once the tech in the back captures the left ventricular pressure, you will then hook up to the power injector and do a LV-gram, left ventriculography. That's where you evaluate the dynamic function of the heart. Okay.
So all the muscles
you get your
and whatever
ejection
it is.
fraction from that. Okay. Once that's done, okay, once you've injected, the doctor will reconnect to the manifold, flush the catheter again, and then they'll say this, ready for pullback. What that means is they're asking the tech in the back that's monitoring, get ready because I'm going to pull back from the left ventricle across the aortic valve with my catheter remaining in the ascending aorta. That is crucial because you're evaluating for any type of aortic stenosis or valvular disease in the semilunar valve, right there, the aortic valve.
So it'll
If you
pick
miss
up
the
on it.
pullback, that's not going to be a good thing. The doctor's not going to be happy. You can splice pressures together, but it's more accurate to watch that catheter pull back because you're going to see a pressure waveform on the screen, which you'll learn later, okay? But ready for pullback? Ready? And then the doctor's going to do this. They're only going to pull the catheter back twice the distance, 10 centimeters. Because how big is the ventricle? That's about the size of the left ventricle. The heart is only the size of a human hand,
Right.
and the left ventricle is exactly that size. So, I mean, look at the distance between, now that ascending aorta is a little short, but it's really only 15 centimeters, so I'm really just doubling the distance of my catheter, making sure that the pigtail is no longer in the ventricle, but in the ascending aorta. And here you can see it's actually at the distal part of the aortic arch. So, all right, and then the doctor will do this. Disconnect from the manifold. That's your sign to have the wire ready. Okay. Wire goes in. When I get to about right here, I meet resistance. You guys are going to learn this. I'm going to stop you. When you have about 40 centimeters of wire hanging out, that means, and I'll take this out so you can see this. That means my wire is right here. So when I advance, I'm going to feel resistance. Now, I told you at the top of the procedure, if you meet resistance, stop pushing. Here, you have to get the feel for what it feels like to straighten the pigtail out. And if you don't believe me, watch. Here comes the wire, right there. I can feel, when my wire gets to the end, I can feel my wire right here at the end of this pigtail.
But you would know in
And then you
time that
straighten the pigtail out like
by
this.
what you have left in that wire that you're hitting your pigtail.
You can,
In
you
time,
can,
you will
absolutely.
learn that, I would think.
Absolutely you do.
Yeah.
And that's why I said, I mean, without, you see me looking at the wire, I'm not even looking
Right,
down here.
right.
I can tell you right about here.
Right.
The wire should be right at the tip of the catheter, and watch.
Boom, there you go.
There it is. You can feel it. At times, you're going to know, well, about 50 centimeters of wire sticking out. I'm going to be towards the end of my catheter, as long as you have a 145 centimeter wire and a 110 centimeter catheter. You get to learn that. So 40 centimeters of wire hanging out. So, but you never want to pull a pig. Will doctors pull pigtails out like this? Yes. As you pull a pigtail out, coming down the aorta, you run into all the thoracic arteries coming off the aorta. You scrape the aorta. You can select the celiac axis, the SMA. You can select the renals. You can select the IMA, the lumbar arteries. You can scrape every artery and perforate or dissect every artery coming down. But doctors still do it. They'll pull the pigtail out with never putting the wire in. When you guys are in doing this yourself, I want to see this. So when you pull that catheter and wire out, you have wire ahead of the shape of your catheter. And you should do this with every catheter.
Do we need to worry about this catching any
No,
stent?
this is atraumatic. That's an excellent question, but this tip will not
Okay.
say anything. You feel the difference between how soft the tip of this wire is. You can just take your finger and go how soft that is, and then feel how jagged and rough that catheter is. Huge, huge difference. It's an excellent question.
I have one at home, so looking at it.
This last part that I just did, from the LV to the power injection to the pullback, you guys are going to learn how to do it. Because some doctors, once they get the pigtail across that valve, are breaking scrub and they're back dictating, leaving you at the table to finish all this. So I will teach you guys how to do this. That'll be, we won't start the pullbacks until Clinic 2. Okay? So we need to learn how to do heart caths first before we start doing pullbacks and everything. So, questions? That's the left heart cath. We just did.